So our panelists today are going to be Jeremy Hoog from Downtown Emergency Services Center, Dr. Allison Berry from Clallam and Jefferson County Departments of Health, and John Ehrenfeld from the Seattle Fire Department. If you don't mind introducing yourselves really quickly, and then we'll get into it, and then we'll have the panel discussion. If at any time you have any questions or comments, please throw them in the chat and Q&A.
Well, good afternoon. Can you hear me? Oh, that's good. The headphones are always tricky. Okay, my name's Jeremy Hoog. I am the nurse care manager for our opioid treatment network at DESC, the Downtown Emergency Service Center in Seattle in Pioneer Square area. And I've been in this work for about 3.5 years now.
My name is Dr. Allison Berry. I'm the health officer for Clallam and Jefferson counties. So I lead our two public health departments on the far west end of the state. I am also a family physician, and I work part-time at one of our local MOUD treatment centers, Jamestown Healing Clinic. So I also bring that perspective here as well.
Hi, my name is John Ehrenfeld. I am the program manager for the Mobile Integrated Health Program, which is a collaborative between the Seattle Fire Department and the Seattle Human Services Department. I oversee our co-responder Health 1 teams, which includes our Health 99 unit, which is a response team exclusively focused on opioid overdose.
Great, thank you. Sierra, if you could go to the next slide, and we're going to go ahead and start with Jeremy.
Right on. So DESC has had a buprenorphine, a low barrier buprenorphine program for, a few years now, about 7 years. It started in 2017 and mainly really around Suboxone delivery. But we have moved into distributing Sublocade, administering. We actually, I guess it'd be tomorrow, we'll administer our 40th monthly injection. So we're up to 40 a month now, right now, which is fantastic. So what I'm going to do is I'm going to talk about our Sublocade program at DESC. Next slide. I wanted to start by really talking a bit about the population that we serve, particularly just kind of, framing them a little bit. It's a pretty unique population in some ways. The majority of all of the people that I am working with have been unhoused at some point in time, or are living in permanent supportive housing sites, of which DESC has like 18 permanent supportive housing sites, as well as multiple emergency shelters. So we have people living in shelters as well. All these individuals are diagnosed with pretty much severe OUD, often significant mental health diagnoses as well, things like schizophrenia, borderline personality disorder, unspecified psychosis, all sorts of things. The other thing about this population, I think it's kind of interesting, is that many of them have a history with MOUD. And out of this 40 plus injections that we now have, I have a handful of people that I have gotten to work with for the whole time I've been at DESC for almost 3.5 years, who up to this point had been using films, the Suboxone films, on and off, and were never able to stabilize, and found that they were able to stabilize with Sublocade. And so I will talk a bit more about that as we move along. But many of these individuals also have a strong history of trauma in their lives. And the reason that I put up the King County overdose statistics for 2023 is that we saw nearly 1,400 fatal overdoses last year in King County. And DESC had 13% of that population in our system. So not necessarily receiving services at the time, not necessarily housed at the time. That was maybe close to half of that number, but 13% of individuals had touched or had contact with DESC either in 2023 or in 2022, which I think for us is a pretty striking number. So next slide. I'll talk a little bit about what Sublocade is in case people don't know. So we'll start with Suboxone, which I hope many have heard of. But Suboxone is the active ingredient that we use in that to treat opioid use disorder is called buprenorphine. And you'll hear it called Suboxone, Subutex, or buprenorphine. And now you'll hear about Sublocade or Brixadi. So there's various formulations, but the thing with Suboxone, the films that some people may be familiar with, is you have to take those every single day for the most part, right? So you got to wake up, you got to make a decision, you got to take the films, and the films are fantastic for somebody that can achieve that on a daily basis. But what we also have now is something called Sublocade, and it's the extended release form of buprenorphine. So it's an injection every 28 days or so. It's given in the abdomen. It can be a bit painful. To help mitigate that, we give an injection of lidocaine, and then we follow that lidocaine with the Sublocade injection. And if you make all your marks right, it works out fine. If you miss the lidocaine, it still burns a lot. So I think we're getting better at that. But the injection leaves a bit of a lump in the abdomen that dissipates. 3 to 6 months is what we hope. Some people seem to dissolve them much faster than others. Some people end up taking sometimes longer than that 6 months to actually have that lump dissolve. And then the other thing to keep in mind with Sublocade is it takes usually for the clients who we're working with somewhere around 4 months to really kind of stabilize on the medication to where they start to see significant changes. And we'll talk about what those changes are a little bit. But sometimes faster, sometimes a little longer. Next slide. So I think what is unique about our program and what's great is we're hearing that lots of agencies are expanding to be able to do Sublocade via outreach, which is fantastic. So our low barrier program, what does that mean to us? It means we have no appointments. People just walk in and get services Monday through Friday, 9 to 5. And they usually get an intake, honestly, within 5 to 10 to 15 minutes if they walk in. We've kind of prioritized our whole program around the idea of providing access. So when people come in asking for Suboxone or Sublocade or buprenorphine or whatever they're asking for, even, Vivitrol, we'll talk to them about that. We do administer some Vivitrol, but we really work to meet people where they're at. And so if they walk into our clinic, they can get an intake like that. If they call us, they can get an intake over the phone. If they would prefer that we come out and see them in person to do the intake, then we usually can get somebody out that day or next day. But oftentimes we're able to complete things over the phone and then get medication ordered and then follow up with outreach. But what we do with the Sublocade, so it's got to be refrigerated. And we have a handful of medical grade coolers that we use. And when we go to give Sublocade injections, we load the cooler with Sublocade and we go out and visit people in their permanent supportive housing site, scattered site apartments, wherever they happen to be, and give them their injection. And there's really kind of two kinds of injections here. We have the follow-up injection for somebody that has already been receiving Sublocade. Pretty painless, not much of an issue except for the actual injection site. But we also do inductions in the field in people's homes as well. And that is a whole different experience that ranges from that was okay to that was pretty hellish, right? Like it's kind of the whole gamut. And, if one of the things that really helps people is if they stabilize on sublingual films prior to the injection, and then the injection can be pretty smooth. But in our population, it's very difficult for some people that we work with to do that. And then eventually they may ask us, I just want to do this and I want to get it over with today. And if you can picture the reality that if withdrawal without medication could take upwards of a week to resolve, And if you give the medication without any sublingual buprenorphine lead-in, it may be that you are compressing a week's worth of withdrawal into, 8 hours, 12 hours, sometimes 48 hours. So we're really compressing this withdrawal timeline, which is fantastic for if you kind of zoom out and see the overall time that it took, but can also be really, 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 really difficult for the individual. However, the few people that we've done that with are doing well today and continue to get their injection despite the experience that they had, which was really, really rough. And so we have found, we started doing kind of high dose inductions in a clinic setting, and we quickly kind of retreated from that and moved to, because so many of the people we work with are in permanent supportive housing, we moved to actually giving it, doing those inductions in their rooms or their apartments, just because we found, well, one, our clinic is 9 to 5. And if you're a clinician and it's 5 o'clock and somebody's in precipitated withdrawal and you're like, well, you got to go now. That's just a terrible thing. That doesn't work at all. So that was one barrier we had. And the other one was that people are just more comfortable in their own home, right? And in their own room. So we really strive to work with individuals to make this happen in their own space. Next slide. And last slide. I wanted to speak a bit on SUBLOCADE and harm reduction. So many of our clients at DESC that are taking Suboxone, buprenorphine, SUBLOCADE continue to use fentanyl. And the thing about it is that from a harm reduction lens, they continue to use fentanyl, but what they don't do is they don't overdose. And especially with SUBLOCADE, like if somebody's taking medication, nothing is guaranteed, but we just don't see it, right? And we have, I think, somewhere around 255 people enrolled in our program at the moment. But people that are involved in taking medication, even if they continue to use opioids, they just don't overdose, right? And in our environment, we just really, that's something we find to be very, very important, especially as we talked about that number in the beginning of DESC clientele being, making up 13% of those fatal overdoses in 2023, something we are really a number we want to lower, right? In SUBLOCADE compared to films are fantastic, especially for people that can take them every day. But SUBLOCADE offers choice over time, as we kind of like to talk about it. And when we accept the reality that relapse is part of opioid use disorder, right? That people kind of come and go from their opioid use. What's really cool about SUBLOCADE is that they get this injection, and over the month they can have all sorts of experiences, right? They can use, they can not use, they can have a period where it's like they feel pretty good, and so they're not using much in the way of opioids, or something could happen in their life. Maybe we see members or clients that live in housing pass away. This happened recently with a client, and that was pretty devastating for one of our clients, right? And so use kind of spiked for this individual during that period. But there's almost this feeling of like, when we kind of ride this bit of a roller coaster and you got SUBLOCADE on board, you can kind of relapse without the consequence of overdose. And like, this is something we can provide people, which is, I think about it in terms of, I don't know if we could really solve the opioid crisis, but I do think we can solve the opioid overdose crisis. We have tools to mitigate that, right? We also have tools for OUD as well, but we really do have some great tools to mitigate overdose. And if, not using opioids is the goal, which we do have a handful of those people, then we have people that are only getting some SUBLOCADE and are like 5-6 months in and using no fentanyl. And the couple that I have that I know about are also individuals I worked with for the whole time I've been here that could not stabilize on films. And one of these individuals recently just moved out of shelter, got a place to live, and got a GED. And this is somebody that I worked with, on and off regularly, and just could not regularly take films. and this person's doing great. So that's kind of my spiel on our Sublocade program at DESC.
Thank you, Jeremy. So we're going to go ahead and hold questions until all of the panelists have had a chance to talk, and then we'll go through them. Please keep putting them in chat and in Q&A. We've already seen some really great things. Sierra, if you don't mind taking down the slides, we'll go ahead and move on to Dr. Berry.
Hi there, and I will, I'm one of those folks that actually likes answering questions as I go, but I will follow the rules and we'll wait until the end. But there are some really good questions, so please know we will get to them. And some of them I might touch on a little bit in my presentation. So I don't have slides, I just hate PowerPoint personally. But so I'm a family doc. I've been working in MOUD since my training, and particularly kind of bringing a rural perspective to this process. So I trained at Harborview, actually. I worked with DESC a lot, but then I'm out in Port Angeles and SWIM working now. And it is a different ballgame out here. We just have a lot less resources for folks. There's just very few options for what people need. And so a lot of what we've had to do is really build those resources from the ground up. So particularly I was asked here to talk about community paramedicine and dosing buprenorphine on site for paramedics. And I know John's going to be talking about something similar, I suspect, but I can talk about how it's gone out here. So one big question is like, why would we do that? Which actually touches on one of the questions I saw come in, which is the idea that Suboxone, Sublocade, buprenorphine, these are all variations on the same drug. How does that prevent an overdose? And so that means you need to understand a little bit about brain physiology. So we all have these opiate receptors in our brain. Opiates bind to those. If you take a bunch of them, they make you feel high. If you have too many opiate receptors that you've grown over time, it just makes your withdrawals go away. Opiates bind them a certain level of strength. Buprenorphine, which is what's called a partial opiate agonist, binds them even stronger. So if you have, say, fentanyl on board, buprenorphine will actually kick that off. And that's actually what gives you precipitated withdrawals, but it also will hold on. So even a Suboxone or buprenorphine strip lasts about 24 hours, which means if you try to take fentanyl on top of that, those receptors are covered. There's no room for additional opiates to get in there and cause you to overdose. Of course, I think, as a treatment provider, we all prefer that our patients don't use it all, but many of my patients do. Relapse is a part of this disease. And so what is incredibly helpful is when my patient does try it out, have a bad day, see what happens, then if they're already on buprenorphine, there's no room for that to actually knock them into an overdose. And they often don't feel any effect at all. And so that could be really helpful in their recovery process and certainly be really helpful in keeping them alive. So I've been prescribing buprenorphine in the outpatient setting for years, but one of our big challenges was how do we help people get to treatment? One way, there's the folks who have found us already, who have insurance and cars and know how to navigate the healthcare system. And then there's this whole other massive group of people who are not getting served by our systems right now. And so how do we help them better? And so one of the parts of that, one of the biggest things we had to do out here was actually just build treatment capacity. So have places for them to go and make it easier to get in those spaces. And in Clallam County, that's been a huge effort. And we've had a lot of success. So when I first moved out here, the wait list to get into medication treatment for opiate use disorder was about 20 to 30 days, which is like, if you work in the field, you need to get to someone within about 24 hours that they're ready. And so in 30 days, they just relapse and often die. And so in Clallam, we've been able to shorten that. And now we're down to about 24 hours, at least if it's on a weekday. We don't have a lot of weekend options right now, but we really can get people in. And that's been huge. Jefferson, we've still got a little ways to go on getting people on board with scaling up treatment options. But as far as community paramedicine, one of the things that we were starting to see is we've, just like everyone else, seen a big surge in opiate overdoses when fentanyl hit our community. Fentanyl got here a little later than it got to Seattle. We saw it starting here about 2 or 3 years ago. And so it's very new for our population. People are not used to it, and people are overdosing quite frequently because they are not comfortable with the how intense the drug is. So what we noticed was we actually were seeing people overdose repeatedly, even in the same day. So we've done a ton of work on scaling up naloxone access and making it widely available. We've got these naloxone mailboxes that have been very popular. We've been distributing through the exchange forever. But people were overdosing and then taking naloxone or getting naloxone from our paramedics if they've been called. But if anyone has worked with folks or experienced an overdose yourself, many of you know after you take naloxone, you feel terrible. You are thrown immediately into withdrawals and your body feels like the worst withdrawals you've ever had. And so the strong driver for people to use again is just to make that feeling go away. And I think understanding that is really critical because when we talk about this, when I hear people who don't work in the field talk about it, or people who just don't work in opiate use disorder, they're like, this guy just overdosed. You would think he would stop after that. And that makes sense if you've never felt how withdrawals feel. And so patients want to make that go away. And so one of the things we started brainstorming with other partners in the community and some of our neighboring jurisdictions was, can we make those go away? Right, previously our treatment protocol for folks after an overdose for their withdrawals was things like Zofran for nausea, which is just a nausea medicine, things like Benadryl, which is just like, that's just nothing compared to what people are feeling. So what if we actually gave them a medication that specifically makes those withdrawals go away? And buprenorphine does that. In the outpatient setting, one of the challenges to getting folks on buprenorphine is they have to go through some degree of withdrawals before you start them so that you don't trigger that precipitated withdrawal, that sudden terrible withdrawal. But if they've already had naloxone, they're already there. And so we can help make those symptoms go away right on the spot. And so that program is just starting here. We are just starting to build data from it. But we're really hopeful about it. The kind of multi-pronged goal of it is to treat folks with withdrawals so they don't have that desire to go out and use again immediately. To give people potentially a positive experience with the medication. So a lot of people are scared about buprenorphine. They've heard about withdrawals, they're not sure how it works. And so if they can feel it, make their symptoms go away and realize that it's not as scary as they might have heard, that can help them get better and maybe be more open to treatment down the road. We do, in the health department, we do want folks to eventually be able to get to treatment if that's in their desire plan. We don't ever force anyone to do that. But you don't have to be willing to go to treatment in order to start this medication. It can just provide you protection against overdose for the next 24 hours, which is the other main goal of it. And the last big goal actually is just to give our first responders another tool. So I come to this as a doctor, but I work very closely with our fire department. I also come to this as the sister of a firefighter, and I can tell you the burnout is real out there. These very caring people go into this job, but they do burn out after seeing folks, especially actually seeing folks overdose repeatedly. And the biggest thing that I hear folks say is that they feel like they don't have anything useful to give them. And so one of the hopes is to give them something else that might work a little better, paired with making sure that there is a treatment option if they're interested and ready to go straight from that. And so we've had a lot of success with that as well. Only last thing I'll say on this topic, and then I'll pass over to my other panelists, folks, is it was really interesting to me when I started talking about this locally. There was a lot of questions about can we even do this as paramedics, give out this medication? I said, well, as paramedics, you can give Dilaudid, you can give ketamine, you can give all kinds of really intense drugs. Why do we treat buprenorphine differently? That is much safer than a bunch of the stuff you can give. But we still have this idea in our minds of this buprenorphine exceptionalism, that this is a thing for people, for drug treatment providers. It's just a medication. It's safer than a lot of the stuff we prescribe, and it can be done safely. In the clinic where I work, we have nurse managed protocols that I don't even have to see that patient to make that happen. And we can build something very similar for our paramedics, which is what we're doing here. And I will pass to John.
Great. Thank you, Dr. Berry.
Great. Well, thank you. I am very firmly alongside Dr. Berry in the no PowerPoint camp, so I'm just going to chat. So we started an overdose response unit in July of last year, and the numbers of overdoses fire and EMS in Seattle have been seeing really started skyrocketing in 2022, and certainly that's not Seattle specific. We've seen that around the state, but we received a direction from city leadership that we were going to put an overdose response unit within our Health One team, within our co-response team, and really just focus very narrowly on fentanyl and opioid overdose. And so it's developed quite a bit in just 9 months, and we have learned a tremendous amount in that time about overdose and post overdose care and withdrawal and navigation. But I can share a little bit about what we're doing. So one of the first questions really is why should EMS be involved in this, right? Like obviously EMS has a role in managing an overdose in that it's a medical emergency, but why should it be involved further? And there's a couple of reasons. So one is that we have by far the best information of anyone out there of where and when overdoses are happening. We have a real-time window into overdoses everywhere in the city. And we don't know everyone. Sometimes they're managed without calling 911, but in general, we know. And we know the individuals. And that allows us to shift the modality a little bit from standard EMS, which is, you're doing just response only. You wait until the bells hit, and then you go out and you respond to the emergency, and that's that, into a more proactive vision where you can identify people who really can use help and outreach them and try to do some prevention measure. The statistics show that, if you have a non-fatal overdose, your chances of dying of all causes, not just of overdose, basically rise extremely dramatically. And then particularly within the 30 days after overdose, you basically have a 1 in 20 chance of being dead in that next month. And even when in the next year, it stays very high. So, even when we go out and resuscitate someone in the field, that person is extremely vulnerable. So we want to intervene there. So EMS is mobile. We can go anywhere in the city. We can move quickly. We can get there in a very, very narrow window of time. And I think speed is really of the essence in this emergency for a number of reasons that we'll go into. So generally, our overdose team has been going out. We get there as fast as we can. It's a combination of a social worker and 2 firefighters who have special training. They get there. They can go lights and sirens. They get there within a couple of minutes. If the person is still unconscious, they'll assist in the resuscitation. But really, the work starts once the person is awake. So, in Seattle, and again, this will be true almost anywhere in the state. There's really 2 things that happen in the status quo right now. One of them is that the patient walks away. They say, "Nope, I'm not interested," or "I'm in withdrawal and I feel terrible," and they just disengage and leave. And that's obviously very bad because nothing. You're not advancing their recovery at all. I mean, you've saved their life, but you're not meaningfully advancing their progress. The other thing that happens is you take them to the ER, and I wish I could report that the ERs are good, holistic, wraparound places for people to be after an overdose, but that would be inaccurate. And in Seattle and again as other places, the ERs are completely swamped. They're overwhelmed. They're bursting at the seams, and so a lot of the service connections and the social work that theoretically could happen there is not, because they have such intense pressure at all times to medically clear patients and then get them back out the door. So again, this is an argument for community level engagement that Jeremy and Dr. Berry talked about, and engagement through EMS. So once people are awake, we engage with them and we try to talk to them, and we are extremely client and patient centered. We do not have a protocol that we are trying to put people into. We let them lead the conversation. And if someone wants to talk about shelter and they don't want to talk about fentanyl, that's fine. We'll talk about shelter. If they want to talk about, getting a case manager, that's fine. But we will give them as many options as we can. And to Jeremy and Dr. Berry's point, there are a lot more buprenorphine resources than there used to be. So my team does not have to take people to the hospital. We can take them to the Pathways Clinic, which is a buprenorphine clinic in Seattle. We can take them to the Hobson Clinic, which is a low barrier primary care clinic. We can take them to where Jeremy works at the 216 James Clinic and get them established there. We can take them home if we need to. We can go to the pharmacy. We can call in a bupe prescription through the 24/7 line that I want to make a plug for in King County, 24/7 bupe teleprescribing. Get that done, take them to the pharmacy and get their prescription done. In early February, or in early March rather, we started giving buprenorphine ourselves in the field. So right now this is limited to just a subset of paramedics in Seattle. We are hoping that the Department of Health will authorize us to start giving this drug at the EMT basic level for a number of reasons. But right now, someone wakes up and they're in withdrawal, or even they don't even have to have overdosed. If someone is just in withdrawal, period, we can give them buprenorphine. And again, to address Dr. Berry's point, we talk in EMS, especially at the paramedic level, a lot about contraindications. So a contraindication is a reason that you can't give a drug, and very often it's because of certain vital signs, because of medical history, because of a number of other things. Buprenorphine has very, very few contraindications. It is safe to give, and we have now had about 25 or 26 administrations. My team gave 16 milligrams in the field yesterday. It is safe and effective, and it works incredibly well. The research shows that just drugs like Zofran alone are not adequate to address withdrawal symptoms, particularly the precipitated withdrawal you get after high dose Narcan. What is effective is buprenorphine. And what we're seeing, even in this very early stage, is that the people that we give buprenorphine to, we are much more likely to be able to engage with them in the next 24 to 48 hours. And and then follow up, and that follow up might be then connected in with a physician who can give them that 30-day long acting Suboxone injection. So I think these are sort of glimmers of hope. It's been frankly a pretty grim time lately with the numbers that we're seeing, but again, I really think that the increased access to buprenorphine, and I do want to put a pitch in here for methadone, which has also a very important role in overdose use disorder treatment. Expanded access to both of these drugs, I think, really is kind of a pathway forward. And I think that, EMS and first responder and sort of community-led interventions around the state really are going to be one of the keys here. To to moving the needle. Very briefly, since I see it in the chat, and I'll just kind of end with the answer to one question here, which is 24/7 prescribing. There is now a Bupe teleprescribing hotline in King County. It is staffed by Harborview physicians, and one of our main program partners is one of the docs who's going to pick up the phone. It is extremely low barrier. You do not need to have insurance, and they will work with basically any pharmacy you want to work. We call it ourselves sometimes from the field if for whatever reason we're not going to give it ourselves. And so, yeah, thank you, Jessica, for putting that that link in the chat. But yeah, we've had really good success right now connecting people with that one. And with that, Allie, I will turn it back to you.
Great, thank you. So there've already been a couple of questions, so I was going to kind of walk us through that, and if more come up, we'll go through that. So Christopher said, just curious about individuals that are homeless. Can they still get the injection in the field? I believe that's for Jeremy.
Yes, absolutely. That is not a barrier, and we have done that. The real issue there is follow up and making sure there's some kind of plan to give support should they go into precipitated withdrawal, especially if they were somebody that had not had a bupe lead in. But an example of somebody like this would be, we have some pretty disorganized individuals that come through our system at DESC, and we've had some that have a strong desire to reduce or stop their opioid use and have had difficulties maintaining Suboxone films, and they have expressed they wanted the injection, and so we have done the injection with them and been able to manage that.
Great. Is there any kind of like special things that need to be dealt with for the other types of buprenorphine prescription in the field when you're working with EMS? Is there anything special when dealing with a houseless population versus somebody who is unstable or permanently housed? Either Dr. Berry or John?
I'd say many of the folks that we work with are not housed. That's a pretty common situation. The biggest challenge, I think, in a lot of this work, and actually one of the other questions kind of touched on that, is trying to find a good follow-up plan for folks, which is always more complicated for my patients who live outside. One thing that I've come to say is, if you've gotten all the way to me at a treatment facility and you've got opiate use disorder and you live inside, we can get you better. Like, if you want this, we've got good medication. It works really well. But when folks live outside, there are just so many barriers to their success. And that is continuous throughout the treatment process. So whether that's EMS or when they're in clinic, one of the biggest things that anyone could do for any of my patients, even more than me, is get them inside. As soon as my patients get into some kind of housing, they do better. In the meantime, we're just going to do what we can. But many challenges we see are access to stable phones to set up any kind of follow-up or to come. A lot of my patients are struggling with mental health disorders at the same time. And so trying to track the dates of their follow-up or when they're supposed to come, that's all very tricky, especially if they don't have transport. In a rural area, we don't have good transit. You actually need a car to get to most places. And so that's a big barrier for folks. As far as administering buprenorphine, it shouldn't really change our protocols for folks. They're usually outside when we're giving them those medications. But kind of to that follow-up issue, I think difficulty arranging follow-up is a challenge. And I think that sometimes stands as a barrier for EMS even giving the medication. And we are hoping to change that in two ways. One, I want to make sure there actually is follow-up more available in both of my jurisdictions. But also, I would like to see if we can change the culture to that getting a dose of buprenorphine to treat withdrawals doesn't have to mean you're going straight into treatment. It can just protect you for today, and that's something. But I think as physicians, we feel like once we take a person, once they're one of ours, we're responsible for them going forward, and I think that's a good thing. But I don't want it to cause a barrier to us taking care of people in the emergent settings. Long answer to a short question.
John, did you have anything you'd like to add to that as well?
No, it makes sense. So I'm fully on board with that. Just to kind of, weigh in on kind of peripherally on services to folks experiencing homelessness. I think there's a lot of success out there doing outreach in situ, in encampments and RVs where people are living. There's a strong street medicine element that has been stood up in many places around the state. And again, this is a drug that can be pretty safely administered pretty much anywhere. So again, we can be pretty low barrier with it. Regarding the paramedic initiation, I saw Dr. Carlbaum's note. So right now, our protocol is very deliberately written that giving pre-hospital buprenorphine does not require an ED transport. So we can give it to them, and then if they're stable, then we can follow up again directly to a clinic or to a to a more therapeutic location. I think also, one thing we're working on in Seattle is trying to change some of the protocols in the ED to make the ED itself a lower barrier place. And again, that's not going to be your MOUD, prescriber long term, but at least like if someone comes in presenting a precipitated withdrawal, what we have found in Seattle, and this will be the case anywhere, is that the window can be very short. Like if you don't jump on that quickly, you're going to miss it, and then that person's no longer a candidate to Suboxone. So I think that setting up some standardized protocols for very quick initiation of that first dose at the EMT level, and that would be really the charge nurses and the first providers to see these patients. That buys you a little bit of time, and so we're hoping to trial something like that at Harborview, and I think that may be kind of a pathway forward for some more rural communities.
Great. Jillian Davis did ask, are nurse managed protocols available? So it sounds like they're either not available or still in development. Is that correct?
They do exist in some other jurisdictions. So there are some other parts of the country that are a little bit ahead of us on some of this stuff. And so that is one place where I think we could definitely borrow and not reinvent the wheel to kind of bring those in here. And yes, especially in the ED, there is such a shortage of the medical providers to see folks. Anything we can do that basically gets this whole process started before they even have to see a doctor, and the doctor just clears them, moves them forward, would be better for patients and the emergency department generally. We have a protocol for our paramedics that we're probably going to adjust. It started out pretty conservative just because community that we're in. But I think we can probably move faster in scaling up people's doses to get them more comfortable sooner.
Great. Nicole asked, how well does Sublocade work for cravings, being that it's once every 28 days? And are there any interactions, should someone use well on Sublocade?
So when you are at a therapeutic level, it works great. And for some people, this happens quickly. It's meant to be taken every 26 or 28 days on the insert. For our population, which I would say are above average utilizers, we actually found early on in our process that at about 2 weeks, people were struggling. And so what we've done is we supplement films on top of the Sublocade. And for those really severe cases, we also, Sublocade comes in 300 milligram doses and 100 milligram doses. For some individuals that are really struggling with cravings, we have given a 100 milligram dose 2 weeks in to kind of bump that up and bridge that, and then go on to the 300 milligram. We found insurance seems fine with that. They've sent it to us every time when they're the 2 different doses. But I will say I have people for the first time that have been using fentanyl for quite a while. I just had this experience last week where somebody that went through terrible withdrawals during the process, a week later said that I'm waking up, I'm no longer sick. I'm waking up, I'm no longer in withdrawal, right? And that has been a pretty common theme for many of the individuals that we've gotten to work with. But I will say there are those individuals that are like, I want this to work better than it does. And it's taken them longer and a few more months to kind of get to that point.
I think that kind of speaks to the idea that you need to match the drug to the patient in front of you. So we have a few different medications available, buprenorphine strips, Sublocade is the injectable. We have methadone in a lot of communities, not all, unfortunately. We have Vivitrol for a subset that works for. But for not all patients are going to be the best match for any given thing. So I work in a clinic that also prescribes methadone. And so for my patients that have been using very high dose fentanyl for a long time, many of them will say that both buprenorphine strips and Sublocade just don't quite get their symptoms away. And so for those folks, methadone might be a better match. In the meantime, if we really like the injectable, that not having, for methadone, you have to come every day, which is super disruptive to your life. And not everybody can do that. If I really want them on an injectable, then yeah, we'll do that, where we'll shorten it to as short of an interval as the insurance companies will let us get away with. And then we'll prescribe strips on top of it for urgent cravings. But as far as injectable versus films, people say that the craving coverage is about the same once you're at your therapeutic level. But it does treat pain to some extent, but if you have someone who has really severe chronic pain, methadone is often going to be a better match for them, just for the pain coverage part.
So there's quite a few questions about precipitated withdrawal. A couple of you have mentioned that, especially if someone's overdosing and they're delivered Narcan or naloxone, that can happen. So Aaron asked, are people getting the injection to send themselves into withdrawal purposefully? And then Jennifer also asked, is the first 48-hour window usually a precipitated withdrawal window?
Those are good questions. Dr. Berry mentioned that protocols like the nurse-driven protocols are changing all the time, right? Or may change. I can say that our protocols have changed so much in 6 months, right? In trying to meet the client. And we have had all sorts of experiences with Sublocade. There have been, to answer the one question directly, there have been people that have used no films, tried to use films, were unable to do it, and decided to get the injection, knowing full well that they were going to go into precipitated withdrawal in the process. But they were like, I'm here, I'm ready to do it, let's do it. Today, John mentioned the window, right? Like the window of opportunity. And today's the window of opportunity, we're going to do this. And so that certainly has happened. I can't stress enough that no matter what you have seen as far as precipitated withdrawal is concerned. When people say they're ready, it is so hard to tell them, like, they're not, nobody's ever ready for how extreme, at least it has been with the Sublocade or Suboxone induced precipitated withdrawal. I've seen many people with Narcan get sick, and you're able to turn them fairly quick with films, depending on the situation, right, to feel better. But I have seen some pretty rough responses. And when I say 48 hours, I say that because that's on the extreme end of when we have had situations, and that's only happened a couple times out of the 40. Most of the people really resolve with films and the Sublocade within 6 to 8 hours. And that is if they take no lead in and they go directly in. But we have had people go up to 48 hours, and we just experienced that recently. So like Dr. Berry said, everybody is so unique, right?
Well, and I think it's important, since not everybody on this call has the same comfort with these treatment modalities. Most people don't go in the precipitated withdrawals. So in my patient population, if we're starting you on a buprenorphine-based drug, so Suboxone, Sublocade, we try to get you to abstain from opiates for about 12 to 16 hours. I'd prefer 16, but we'll do 12 if we need to. And if a patient can do that, they often do fine. And so I don't want anyone to leave this call thinking everybody who starts on buprenorphine has to go through hell. They don't. But they do have to develop some withdrawals in order to not get that precipitated withdrawal. So what we'll do is we'll do what's called a COW score, and we'll check them out, and they'll be sweaty and they're starting to feel it, and they'll tell you, and then we start slow and scale it up. And so that's another way to do it. In certain situations, like the DESC population, that's just not an option for a lot of folks. So you're going to see more precipitated withdrawals. But most of my patients don't do that and actually feel a lot better once they start their medication.
Well, that's great to hear. I know that, the goal is usually to help get the person where they would like to go, and no one wants to feel, sick. John, how does your team deal with precipitated withdrawal in the field?
Right now we're still sort of in a little bit of a transition period. So right now, if we're someone who's in precipitated withdrawal, every morning we're going to come in and we're going to check if any buprenorphine approved paramedics are working. If they are, then we're going to see if their units are available. So it's not, we need this drug ourselves. We don't quite have it yet, but theoretically, if you have a bupe medic on medic 10, we'll say, hey, medic 10, let's add you to this call. They'll come and respond down and can give that initial dose. So we can give 16 milligrams followed by an additional 8 milligrams. If there's no medics available, then we're going to plan B, and there we have to get creative. So sometimes it's, we're going to take them to the ER. Sometimes we'll try to get them to the Pathways clinic. Sometimes we'll take them to DESC. It really depends. We don't have a playbook. We can be creative. But sometimes, there's just, we are really affected by just the lack of, landing zones is what my crew told them, like physical places to take people. And again, that window is so short that, sometimes, you're going to plan B very quickly. But in an ideal world, we're giving that first dose for EMS, stabilize them, and then, work on continuing.
Great, thank you. So Michael asked, is there a program that allows for this shot prior to being released from jails?
I can speak to, I know Clallam County Jail does that. And I happen to know that they do that at KCJ too. But it's not universal. I think it depends a lot on the doctor that's working and their comfort with the protocol. I know in Clallam County Jail, it depends on like if they have a nurse that day. And so unfortunately it's not consistent across the board. It's not being offered universally to people who qualify, and that we need to change. There's also, unfortunately, a big economic disincentive. Sublocade's expensive, and your jail medical care is paid for by the jail out of the law enforcement budget. And so that's, we see some hesitancy there, though I should acknowledge Clallam County Jail has applied for a ton of grants and things to try to pay for this. So they are very interested in making this more available, but that's not universal across the state. And there are certainly jails that aren't doing it at all. There is current advocacy at the state and federal level to try to get people's insurance to continue while they're in jail so we could treat all of their medical problems, including MOUD, because it is a weird gap where people lose access to medical care when, by Geneva Conventions, they should have access to medical care. So it does happen, but it's not as universal as it should be. Because it's a great opportunity to prevent, statewide overdoses coming out of incarceration. It's your highest risk time because most people have some sober time while they're incarcerated. And then if there is no wraparound services, if there is no access to treatment, often will relapse near immediately upon leaving after all the trauma that they just went through. And we can prevent that. There are ways to make that better. And so at Clallam, we have a pilot program where we not only can get them started on MOUD, but actually facilitate their entrance into treatment. Someone will pick them up, with a sandwich, and it's a peer navigator, so someone who's been through this before, who will be like, hey, I'm with you. I'm not going to ask you to do anything I can't do. We got this. And that has been incredibly effective. That used to be the group who died the most in Clallam County. And now we haven't had an overdose of that population since that program was built. And so it is fixable, but you have to invest in it.
Pamela in the chat said that Kittitas County Jail has an MOUD program and a new grant to pay for medication, and they'll hope that it includes Sublocade. That's great to hear that Kittitas is working on this. So also in the chat, Catherine said, I think it's one of the reasons it's so important to have more housing first models in Washington State. It's hard for people to focus in recovery or in getting help if their basic needs aren't addressed.
Yeah, 100%. And I think it's also really important. People often misunderstand that relationship. They think that because people use drugs, they become homeless. And consistently, we see the data goes the other way. Losing your housing is an incredible risk factor for moving into using drugs or to relapsing if you were sober before. So we have to meet those basic needs if we want people to stop moving into this, facing this challenge.
I've worked with many individuals in a shelter environment who will consistently say over and over again that I want MOUD, I want treatment, but I want to wait till I'm in housing. Because they're also, even if they're not unhoused and they're living in shelter or unhoused, they're in environments where substance use is so prevalent and it's so difficult for them to make a change. And so those are people that we have definitely worked with and followed until they've gotten placed in housing. And some of those people, like the one I described earlier, that got a GED and is got his own place, was one of those individuals, was like, I think I'm really going to need a place to live out of shelter before I could do this.
There's just so much trauma in living outside. And I think it goes to the idea that people use drugs for a reason. Most people are using to treat something. And if we can stop the trauma that they're trying to treat, that's going to help them get better.
Absolutely, absolutely. So Rose asked, when we first started administering Sublocade, we were advised that Sublocade can't be transported to other clinics, even if it's by the provider. Wondering if Jeremy could discuss transporting into patients' homes. Thank you. This has been great.
Yeah, I'll discuss it. I don't really. So we heard this at DESC, and it's interesting because the community around us in Seattle had that same perspective. We're like, we got to go to where our people are, and we started transporting in coolers. And as a result of that, I think, and kind of expressing that over and over, that's what we're doing. We're kind of seeing it with everybody now. And most of the clinics around us are finding a way to take it out. And I don't know the logistics behind that. I just know I put it in a cooler, take it out, and give it. So I wish I had more than that.
Yeah, we hear a similar conversation, and nobody's come after us yet. And I think sometimes a lot of these programs do take that willingness to be like, look, this is what the patient needs. I don't see any reason why this is dangerous. I don't see an actual law that says I can't do it. Let's just figure out a way to get this done. And I think you kind of have to have that attitude if you want people to get better. I think some of it is just transport logistics of like making sure it stays cold, but like we move vaccines all the time. There are ways to move things that are cold. And just meet your patients where they are. I know we dose Sublocade in the field. So they're doing that outside in the grass. You know, we find a way to get it done. So it's and so far it's been okay.
This question was about Sublocade, but I think that it kind of can work for all of them. So what happens to a person after they've been injected with Sublocade? But I'd also like to hear from John about like what happens to someone after you've administered either Sublocade or buprenorphine.
Yeah. So on the Sublocade front, yeah, I'll probably defer to Dr. Berry there. We're mostly facilitating those, but that mostly comes in the form of just taking people to that appointment. As far as the Suboxone, the sublingual Suboxone that goes into the tongue, you usually see the effect for people in precipitated withdrawal. You usually see an effect within 5 to 15 minutes. So they start feeling better quite rapid, and it's really dramatic. So very bad precipitated withdrawal. I mean, it's not a subtle symptom. People will have nausea, vomiting, diarrhea, full body aches, agitation, yawning, sweating, runny nose. I mean, people have described to us as, like the worst cold you've ever had times 10, the worst hangover you've ever had times 10. People have said they would rather die than go back into precipitated withdrawal. And usually within, 5, 10, 15 minutes, they're feeling much better. The agitation calms down, the restlessness, the body aches. So it really is very, very rapid action through that sublingual method. And and again, that builds rapport, right? At that point, they see that we're an entity that can really help them feel better, and maybe they haven't felt better in a while. So at least on the sublingual front, that's what it looks like.
And I think one other thing to add to kind of the sublingual experience that my patients describe is most patients I see don't like fentanyl, actually. Many patients have told me they would go back to heroin if they could, but they just can't find it. And because of its rapid on, rapid off. And so they feel a little bit better and then they feel like hell. And then they feel better and they feel like hell. And they do that 10 times a day. And that's just a terrible day every day. And so a lot of my patients, once they get to a therapeutic dose of buprenorphine or methadone, they just describe that they just feel okay. And they haven't felt okay in a long time. And so that's probably the most kind of sticking with them thing that I hear. If they're already in precipitated withdrawals, we see that kind of rapid improvement. If they're not, if they were just in withdrawals, so they abstain from using, we tend to see them feel better over the course of 30 minutes to a couple of hours as they scale up their dose if they're going up slowly. So a standard clinic induction, people are taking 4, 8, then 16 to get to most people end up on 24 these days because of fentanyl. And so as they're ramping that up over the course of hours, they start to feel normal over hours. Jeremy, what do you see with your folks when you give them injections?
Yeah, all sorts of things. But, I think for some people, when a situation goes kind of the best case scenario, really within days with injections, they're reporting that they're, like I said earlier, they're not waking up sick, which I think is a really big one for people, right? So they're not waking up feeling like they have to use, they're waking up feeling like they have a choice, more of a choice in what it is that they're going to do. One unique thing we have experienced in our environment and with some of the people that we're working with is a couple, maybe a couple weeks in or a month in or maybe 6 weeks in, we sometimes, for those individuals we work with, and we work with a lot of them with severe mental health diagnoses, have also seen an increase in those symptoms. As Dr. Berry mentioned, everybody's treating something, right? They're treating psychological issues, they're treating, psychological pain, physical pain, all these things, right? And so when people, even if they continue to use, now they're having a different response to that use, right? And that's confusing. So now they're living in this world where it's like, well, I'm using fentanyl, I'm not getting the response, I'm feeling something, it's different than it was. And then we've had a couple people who, experience a lot of like auditory hallucinations in their life due to their diagnoses. that those things have really kind of come to the surface, right? That you see that fentanyl was actually treating and pushing down some of these things for them that kind of allowed them to go through their day. And so we've worked pretty hard to make sure that they're connected with mental health providers. So that's kind of a unique situation too, that we have seen like, wow, these things seem to get worse, because they're recognizing them for the first time. But especially OUD feels like with Sublocade or Bup, especially with taking, and especially methadone, which is fantastic. We just don't have that resource for our population really in the way that it needs to be accessible. But OUD feels like it can be controlled, and I've seen it with patients, which is really cool.
And just a brief note on the mental health stuff. We are very lucky that we have access to psychiatric services in our MOUD clinic. But one thing I always counsel my patients as they start on medication is it could go either way. They might find that their mental health gets a lot better because they're not swinging between methamphetamines and fentanyl, which is what a lot of my patients are doing. A lot of them thought they had bipolar and they just had methamphetamines and fentanyl, and now they don't anymore. And so some patients get a lot better, but other patients do get worse. If they were self-treating generalized anxiety, they often will feel that really come to the fore. If they were self-treating depression with methamphetamines, they're going to feel that too. And so you want to be available to your patients to help them with that and get them on a better medication. Fentanyl is not a good treatment for anxiety. I have much better treatments for anxiety. And I have had patients say that too. I had a very nice man who'd been on opiates since he was 17, and we just got him on regular anxiety meds that like probably plenty of people on this call are on. And he was like, man, if I had had this, I don't think I ever would have used this. And I think that speaks to access to care as a critical thing for folks too. So many of my patients just needed regular medical care. And unfortunately, it was easier to access fentanyl than it was to access that. So that's another part of prevention that we need to work on.
Wow, what a statement right there. And I think it does speak to a lot of the barriers that people are perceiving. And we often talk about, barriers to getting MOUD or barriers to getting to an inpatient, but it can be so much more than that. This, can start so much earlier. Pamela in the chat asked, does Sublocade still only come from specialty pharmacies and RX written for a specific patient, or do you have a supply of medication that's also available for anyone who wants it?
I mean, we're really lucky in that we work directly with a particular pharmacy. And honestly, we're able to call them and I can go pick it up within the hour kind of thing. So I'm so grateful for our pharmacy that we work with. They're fantastic. I don't know how it works outside. I think I'm living in a little bit of a different world that way.
Out where I live, we have to prescribe it for a specific patient, which is frustrating because we have to get it sent to the clinic. So we can't do like that same day. But in specialized settings where it can be pre-ordered, that can be done. But you just have to build the infrastructure for it.
And Dan said that was hitting the nail on the head. Self-treatment of issues is easier to get. If that barrier was removed, it would change the whole game. So in the Q&A, Michael asked, what kind of feedback do you get from individuals who are currently using Sublocade but have also used methadone and or Suboxone in the past? How does it compare?
Yeah, I mean, methadone, obviously we prescribe Sublocade. Methadone's been mentioned many times. I will say that once in a while we have people come to us that are on methadone and want to switch. We counsel heavily not to do that. It's been mentioned here, the pain control with methadone, so much better. And just it's going to give you something that you're not going to get from Sublocade probably and from Suboxone for sure. And so, for us, it is about a particular population. Honestly, I think if everybody had access and we had the kind of, like we could prescribe methadone, I think we would prescribe a lot more methadone. for individuals. And I think we would be a lot more successful in helping people treat their OUD in some ways, but it's just not the position that we're in.
I would say some of my patients do switch off methadone to Suboxone or Sublocade. Most common reason for that is usually just life circumstances. So they can't come as often. People they start coming every day, but if you've been doing well, you can space that out and you don't have to come every single day. But it's still a lot. It's a lot of checking in. And as people's lives get more stable, they don't always want to do that. I have had patients who have to switch because they need a CDL. So we have a lot of log truck drivers out here, and you can't get a CDL on methadone, which is something we need to change. But you can get it on Suboxone. And so I've had patients who have to make that switch for economic reasons. And so we just do it very carefully. We counsel them on the risks. Anytime you change someone's medication for opiate use disorder, your risk, thank you, Allison, CDL is commercial driver's license. So if you want to drive a truck. Anytime you're changing a medication, your risk of relapse and overdose goes up. And so you have to counsel patients on that and be present and available to adjust their doses. We do a lot of microdosing as we switch people over. Coming straight off of methadone into Sublocade, not recommended. You will absolutely precipitously withdraw, and I really try to prevent that. But we microdose, we lower their dose and then microdose Suboxone up until they're at a stable dose. So it can be done. And we've done it plenty of times. But it really depends on the person's indication, and we'll always support them in whatever they actually want, but we need to make sure they're counseled on the risks and benefits of that decision.
Great. John, how does your team in the field talk to people who've had experience with MOUD that was maybe unsuccessful or different when they're trying to, make these connections and provide some sort of treatment?
I think for us, a lot of it starts with the recognition that, we ourselves are not the true OUD specialist for that. We want to connect them with, with a doctor with an addiction medicine specialty or with a specialized clinic. And that might be, again, the Hobson Clinic or Pathways or the 216 James Clinic. So we're really trying to support them in their decision. There's a lot of, I don't want to say misinformation, but oftentimes people will sometimes mix up medication. So if we talk about Sublocade, they'll say, "Oh no, I've had the shot. I don't want that." Well, they're thinking of Vivitrol. So that's a medicine called naltrexone, and it makes people feel pretty dramatically horrible. It's a different shot. So we try to provide some general counseling on this, but basically really say that there are professionals out there, like Dr. Berry was saying, who could really help them manage this transition. Sometimes it's macrodosing, sometimes it's microdosing, sometimes it's a taper. I mean, there's a lot. And again, as EMS professionals, we are not the subject matter experts. We are trying to provide a supportive environment to allow us to connect them to those people. And again, if they need a cell phone, if they need a shelter bed for the night, and if that's the support they need to help make that connection, then at that moment, that's our role, and we can just kind of foster that warm handoff to to one of our clinical partners who can have that in-depth conversation with them.
Great. So David said, Dr. Berry, thank you for presenting. I was surprised when the EMS pilot project reported out that initial field BUP NAL experience earlier this month, and very few have actually dispensed, most related to access to the next step, MOUD clinic. How can we improve access to MOUD? I'm not sure the SFD model of transporting most of these patients is to the ED is good in a rural situation.
Yeah, I think we kind of hit on parts of this question over some of our answers, but I do think, significant increases in access to treatment is a huge need in so many places, and definitely out here. And reducing those barriers that can seem so surmountable when you can navigate the healthcare system. So, in Jefferson, for example, lovely healthcare system, so great, cares so much about this. But when you walk into the front desk, they ask you what you're here for, and they ask you for your ID and your insurance card. And most of my patients don't have those second two. And because people have this history of trauma, they often, when they see that, are like, I'm out. I don't have the thing you need, I'm gone. And it just takes someone at the front desk who has some training in how to handle that to say, hey, do you have this? If you don't, it's okay, we'll still see you. And just that phrase difference makes all the difference in access for our patients. So figuring out where those barriers are for how people are getting in. At Jamestown, we write off a lot of people's first visits because they don't have any of that stuff. You have to have a clinic that's willing to do that so that you can get people in the door and have treatment providers available to do it who understand this issue. In Jefferson County, we have no methadone. So people have to travel into Clallam County. Thankfully, they can get to Clallam County now. For the longest time, we had to go to Everett. Every single one of our patients from Nia Bay had to drive to Everett to get on methadone. So that's not sustainable. And so there's still a gap in treatment access. I think that's the first part. But the other part is convincing folks that it's okay to dose, even if they only get that dose that day. And increasing comfort with this. This is a new program. It's new to a lot of our paramedics to do this. And I think it'll take some time for people to feel comfortable with this medicine. I've been doing this for years, so I'm comfortable with it. I wasn't as comfortable with it when I first started. And so we have to help folks get a little more comfortable.
So how is the Seattle Fire Department working to increase access?
I guess, is this access just in general to MOUD?
I believe, yeah, in general to MOUD.
Mm-hmm. So, I think one of the things we're going to be working on is trying to extend some of the knowledge and the training beyond just our specialty team. So right now our overdose response unit is pretty small. We're going to work on providing more training just to our frontline staff. So, we have 1,000 firefighters, and providing that training and education on how to do those kind of basic service connections. So even if, an engine company in the field can't, navigate someone to a clinic, they can at least provide some information. And then, we're also hoping to work with other city partner, community partners, outreach teams in the field, other alternative responders to give them training. So, if one of the other city teams encounters someone who, say, is in withdrawal and experiencing those symptoms, they can be pretty quickly routed to us. And then, we can take over from there. And so, I think this is, again, this is a collaborative between, the hospitals, the public health department, the community partners, and fire EMS, just to try to get more of this information out there.
Great. And Jeremy, can you talk a little bit about what DESC is doing to expand MOUD?
Yeah, I think in a lot of ways, this is kind of really at the crux of what it is that we're doing is access, right? For the hours that we're open, we're available to do an intake, and those intakes can result in pretty immediate Suboxone films, for instance, and immediate plans to move towards a Sublocade injection. And I think the whole kind of goal for the last couple of years around what it is we're doing is to be able to capture people in that window when that window's open, right? Giving people the opportunity to address what it is they want to address exactly when they want to address it. And I feel fortunate to be able to do that. So we do that. We usually have providers that are willing to take calls if we need to pretty immediately. Kind of as a collective at DESC people, we have a handful of providers, and they make themselves available, if not immediately, within minutes, and we kind of stay with people if they need to talk to a provider, even if our process is pretty nurse driven. So yeah, no appointments and just like total access for the hours that we're open is really what we seek to accomplish.
That's incredible. So Daniel asked, can you describe how you counsel patients who want protective therapeutic efforts of Suboxone Sublocade, but don't want complete euphoria blockade? Curious about folks want medication, but also want to be able to experience the euphoria when they use non-prescription opioids.
I would say most of my patients don't feel euphoria anymore. By the time they get to me, they haven't felt that in years. And so because of, because they've had so much opiate receptor overgrowth, that most of my patients are actually just treating withdrawals. They aren't actually trying to get high anymore. What I counsel patients is that, it is certainly a lot of my patients are on methadone. And so one of the big parts of counseling with methadone is you definitely can overdose on methadone if you take opiates on top of it. And so especially if you're mixing with benzos, if you're mixing with alcohol, which some of my patients do. And so a lot of our conversation is around safety if they're going to if they're going to keep using on top of it. And a lot of my patients actually have to keep using on top of it in the beginning. We aren't mostly talking about methadone here, but there are so many rules about how I prescribe to people that keep those doses so low in the first few weeks. It's just not enough to treat people's withdrawals. So most of my patients use in the first couple of weeks as we get them up to the right dose, which is dangerous because they don't know what they're using. They don't know how much it is. It would be much safer for me to be able to titrate their methadone a little bit faster. That's another issue. But so a lot of it is counseling on risk if they're on a pure opiate agonist. If they're on Suboxone or Sublocade, what I tend to really tell folks is that most of the time you're not going to feel it on top of that. And I don't recommend you use as much as you possibly can to try to feel it. Like chasing that high is dangerous if you pile that on of Suboxone, especially if you mix that with alcohol or benzos. And so most of my counseling is on safety. That's probably the doctor part of my hat. And I don't usually, I don't find most of my patients can even reach euphoria anymore.
I definitely have a few people that are able to reach that and euphoria. And for instance, we actually have one individual that requested to go from a 300 milligram injection down to a 100 to actually allow that to happen a little bit differently, right? We start kind of all of our conversations that we are not expecting you to stop if you don't want to stop, right? And kind of this very harm reduction method of communication. And for our population, we found that it was really important to kind of get the engagement going. And, I think that people would tell you that it is certainly different. But I think that, and I don't know exactly what some of these people that I'm working with are feeling, but I think when they're in certain social situations, especially in permanent supportive housing, they go ahead and continue to use in certain settings. And maybe they're not getting a lot from it, but, especially with Sublocade and Suboxone, it allows them to do that pretty safely, which is nice. But yeah, we had one individual that seems to have proven the insert wrong, that there's a full blockade. And I've seen it and witnessed it. And it's like, okay. And I will say this is an individual using intravenously as well. And was able to overpower a 300. And that was after 6-7 months of injection. But he didn't overdose. They didn't overdose, and that's great. And we keep working with this individual and making progress. And this is still tremendous progress for this individual. So, but more times than not, people aren't getting near anything that they used to get from it.
Well, and I think that is a really important aspect to discuss, is that you're here to support what your patient is trying to get done. And at any time that you bring your agenda to them, it's just not going to work as well. And so a lot of what I do is a lot more asking questions of what do you want to get out of this? Are you trying to get sober? Are you trying to reduce your use? Are you trying to get your kids back? Where are we in this process? Or do you just not want to withdraw today? Okay, we're going to figure out how we help you meet that. And people's goals change over time, So one of my patients might be just, I don't want to feel like hell this day. And they get a positive experience with me. They get a positive experience with clinic. And I might see them again a month from now. And then their goals might be, I actually do want to reduce my use. And so just meeting your patient where they are is really important. And it's hard for us. We have we bring our own goals to our patients, but it is really important to start there, and you'll have a lot more success in the long run.
Great. I was wondering if you guys could touch on the role of peers in the work that you do. Are you utilizing them? If so, what does that look like? If you're not, what would you like to do?
In our clinic, most of our SUD counselors are peers. So I think that is really important. People respond better. And you're going to use better language, better understanding if you understand where people are coming from. I'd say most of our docs are not peers. And so we just have to bring that humility to the work that we bring. In our paramedic program, I don't think we have any peers in that group. But peer navigators has been really important. So the getting people in and out of clinic, and supporting folks. We have a van that picks folks up, and that's been huge. And to have kind of understanding, empathetic drivers who really understand where people are coming from has been really critical.
We have in our program, we have one dedicated peer on staff as a peer, and then and our peer, she does everything, which is wonderful. And then I myself have lived experience and have also gone through the peer certification and all that. And um, I know for me that learning about how to do all this and learning about, being a nurse and doing the medication and all of that is absolutely essential. But I feel like the most useful part of me every day is the peer side of me that just walks in the room and is like, okay, and so we want more on our team. I think it would be really, really beneficial to, like, on every outing to have a peer with a nurse or a peer with the doc. And, our doctor uses our peer all the time, right, to really kind of really build out the team for the day for the individual that we're working with. And it's really, really useful.
John, what about you?
Very briefly, yeah, we recognize kind of the critical role that peers occupy in this work, and we are in the process right now of adding 2 to our team. We're getting those funded through the Washington State opioid settlement, and so I'm hoping to hire them within the coming months and figure out how we roll them into our program, both for response, outreach, follow-up, and general work, because we, in addition to fentanyl and opioids, we do a lot of work with people with substance use disorders, and across the board we can see a lot of application there. So we're very enthusiastic about building that out.
Great. So a question from Q&A. James said, Allison, thank you for the information. Is there any training classes that I could send to our case managers and staff to learn about Sublocade? Today is the first time that he's hearing about it.
That's awesome. Awesome that you're hearing about it. I don't have a class off the top of my head, but I think they'll probably share our email. So I think, is that someone who's in Jefferson County? Feel free to reach out and we can connect you with some folks and get you up to date, because it is a good option for a lot of patients.
So I will also say, since you're asking about questions about Sublocade, Mark Duncan, who is part of the state opioid response team at ADAI, has done a series on Sublocade that is either on or on learnabouttreatment.org or will be soon. So there's also a bunch of resources available from ADAI, and we'll send out links to that as well. Regina said, is it possible to get people on medication to address those concerns beforehand so the transition is easier, the concerns being anxiety, depression, bipolar, etc.?
Yes. So it depends a lot on how good your history taking is when you first take them in, and whether or not they're in a place to give you that history when they first come in. So, my first clinic visit is long. If someone's getting into MOUD for methadone in particular, there's a whole intake process that we have to do. Usually by the end of that, the patient is like done. They just want to get on their methadone. They want to go. But an important part of that history taking is trying to get an understanding of their mental health history. If you can really pull out something that sounds like a true bipolar disorder that's not been adequately treated, or have they been on meds before that worked well for them, you can start them on that before they move forward. So I'm a physician, so I can prescribe all those things. Not all clinics are going to have that option. They might only be able to give medication for opiate use disorder. But if you can, yes, ideally you get them started on something. Many of my patients have never had regular healthcare before this. And it can become really hard to tease apart when if they've had any sober time, where you can pick apart whether or not that's truly a mental health disorder or that's the result of ingestions of substances. But if you take a good history, if they've spent any time incarcerated and didn't have access to drugs while in jail, many people still do. So you have to piece that out. But if you can really get a good diagnosis going, start them on meds as you get them started on MOUD.
So at DESC, how do you deal with that transition if there are other mental health symptoms that seem to be showing up?
Yeah, we have a couple different programs that we can tier them with, which always takes time and then requires an intake, which doesn't always work out very well. I think right now in our program, we're really fortunate in that our medical director spends a day and a half to 2 days with us and is a family doc and addiction medicine doc, and that's wonderful. And then we also have we have a psychiatrist who spends time with us, and we also have an ARMP with psychiatric focus that spends time with us. So honestly, if we have individuals, we're lucky in the sense we can leverage those relationships that we have to send one of those providers out to bridge them while we enroll them into a program and assess those needs. So that's kind of how we've been doing that. It's kind of ad hoc, but it's been working.
And how does EMS handle it if it feels like there are other mental health issues going on when they're responding to an overdose?
I mean, EMS it's a little bit of the Wild West. There's not a lot of firm protocols on this. It's extremely case by case, and you have to evaluate, the client's baseline to the extent that you can figure it out. You have to see what their current level of mentation is, and really whether they can give informed consent. It's completely fine to give Suboxone to someone who has ongoing mental health issues. However, if they're so psychotic or delusional that they can't meaningfully engage, in that case, we probably would forego that in the field and probably refer them to a hospital and hope that could be provided in the ED or in an inpatient basis. So it really is going to depend where they're at, today at that moment.
Absolutely. So we've talked about a lot about how your program is going, but what are where would you like your program to be going? Like assuming that you can get all of the permissions and get things working the way you want, what would that look like to your organization?
Widely available treatment throughout both my counties you could just walk into. That would be great. Right now, we have small critical access hospitals, and neither of them give on-site bup for folks who have just come in with an overdose. So that seems like something we could fix. Getting that set up would be really good. If we could get people in the treatment on the weekend, we just don't have that right now. And that would make a huge difference. And then to get more people doing it. So right now we have our pilot project is with our community paramedics, which is a group of paramedics who've kind of self-selected for caring about these issues and this patient population, which is a great place to start. But that's not enough to see everybody who needs it. And so eventually I would love to see more comfort across the paramedic spectrum, across across all the places where my patients go, a better understanding of MOUD, of what's going on with my patients, so that we could actually really get to that no wrong door model. Right now, it's like 80 wrong doors and like 10 good ones. And so I'd like to shift that at some point.
Jeremy, any thoughts about where
Yeah.
you?
Yeah, for sure. I mean, I think that there's been a really solid focus in our program in providing access and figuring out how to open doors to meet people where they're at. And we have so many intakes a month right now compared to what we had a year and a half ago, right? And we feel like we have accomplished that. We feel like we are figuring out what people's needs are and how to get them medication quick and in the moment, whether they're in withdrawal, whether they want to start medication. I think for us, what I really hope is that we can expand the size of the program so that we can do that better, right? So that we can make connections for people to primary care. We know all the things that we could do for people, but we can't do those things because we really are this access point to get people onto medication and try to sustain medication, right? If every one of the people I work with had the opportunity to meet with a counselor, I mean, like, the research showed those things really go hand in hand. And like, we're a behavioral health organization. We're like, we don't really have that option. It's just not how it works, And so I think just really being able to expand and provide the kind of services we know that really improve your quality of life if you are on MOUD or if you are seeking treatment, from MOUD. So I think just continuing to build out from there. Yeah, we just need to be like 3 times the size, 4 times the size.
Absolutely. What about you, John?
Yeah, I mean, more is the answer right now. More firefighters who are trained, more case managers, more peers, more hours of operation. But again, I went go back to my the phrase that I used earlier, which is landing zones, like a place to take a human being that is not a hospital ER. And so, we have hopefully some good news on the horizon. So we just had a big press announcement with DESC. Seattle's going to be opening up an overdose recovery center, which I'm very enthused about. I think it's a huge step in the right direction. But even just existing services, more low barrier shelter beds, more permanent supportive housing. I mean, it's an ecosystem, right? And one of the main things you learned is you just cannot look at fentanyl addiction in a vacuum. You have to look at all the other things that go along with it. So if I had infinite money, I would spend a little bit on myself and my program and quite a bit more on all these other services out there in the community.
Absolutely. So Tony in the chat asked or in the Q&A asked if a peer wanted to volunteer, maybe not ready for the workforce or go to school, or where would you recommend they start if they already have a CPC, which I'm pretty sure stands for Certified Peer Counselor?
A lot of different places. For another part of my job that we haven't even talked about today, so we have a harm reduction center. We take volunteers. That's often a really good place to start, depending on where you are in your recovery. Some folks don't feel comfortable being around folks who are actively using, but if you're at a place where you feel like you could give back in that way, that's been a good route for a lot of volunteers into our organization. I suspected others as well.
So we're getting close to the end of our time. Is there kind of any like main takeaway you would like people to have from the work that you're doing, or anything that you just kind of want to end on?
I mean, I think one of the things we discussed a little bit ago is like this is an emergency. People are dying. So find a way to get creative. We try to make sure it's not truly illegal, but then do the thing that is needed for your patients, and listen to your patients about what they need, what they don't have, and be willing to push the boundaries a little bit to get it done. That's what we do.
Yeah, I love that. I don't know. I'm okay with maybe partially illegal. I don't know. I think the biggest thing is that I've learned we have options. We have options, and it's our systems that are the barriers to accessing those options. And I think that there's plenty of room for creativity. And I see that happening more and more and more, and I love it. And I think the other thing like that we've learned as an organization, don't be afraid to be flexible. don't be afraid to say, I don't like this method's not working for us. Let's try something else. Like, get creative. We come from a bit of a rigid background sometimes in these environments, and we've had to be super creative. And so I think keep that up, and I feel like it's moving. The needle's moving in the right way, and I'm grateful for that.
Yeah, I would echo that as well. Creativity, and I think I'm less familiar with Clallam and Jefferson, but I know both the fire department and DESC are we're capacitated to think outside the box a little bit. And I think that's really required given the extent and the severity of the crisis. And I think again I always like to end with the fact that drug addiction is not a moral failing. It is a treatable mental health illness, and you got to start and end there.
Absolutely.
Can I give you one last thing, which is to be open to surprising partnerships. So I work in a more right-wing county, and so some of the folks that I work with a broader coalition, and there's a lot more people who support what I do than I maybe would have initially expected. One of our most intensely right-wing commissioners we've ever had fully supports the SSP. And I was like, that's amazing. And so meet people and recruit them in, because you are going to need a broad coalition to treat this. I work with our sheriff a lot, and he's fully on board with MOUD in the jail. So be willing to reach out to partners you might not have thought of, and spend time getting to know them and their motivations for why they do what they do, because you can form a broader coalition, especially in more rural areas like this where you can't work in your silo, you won't succeed. So if you can broaden the folks that you talk to, you can accomplish a lot more.
Great. Yeah, absolutely. Finding allies or other people who are also, adjacent to this work or in this work can be really helpful. So we're kind of wrapping up. I wanted to say thank you to all of you for joining us for this panel. I think that there's a richness of experience here, and it's just really interesting to hear what innovations are going on. The drug supply is constantly changing, and the way that we have to deal with that also needs to change. And so it's great to see, that we have some really great people working on this. So thank you so much.
Thanks for having us.
Yeah. Sierra, if you could put the slides back on, we're going to go ahead and wrap up this panel right now. At 2:30, we will have the adolescent and fentanyl panel. So stay tuned. Thank you so much.
Thank you, Allie.
Hey, Allie, can you hear me?
Yes, I can. And I can see you too.
Hi, Seth.
Hey.
So, Jaden, will Aiden be joining you?
He will. Should I tell him to come over now?
Yeah.
We're going to be on the same screen.
We're in 6 minutes, but
yeah.
That's great.
Okay. Awesome. Great.
Jasmine, is that a Mickey Mouse behind you?
It is. A patient of mine was really into the what are they, Smushmallows?
Oh.
And so they bring them into all of their appointments, and they wanted to share the love. And so they gave me one so other patients can enjoy it.
That's very nice. So we'll get started with the panel in 5 minutes. So if you need to move around, do whatever.
I'm actually, is this part being recorded as we're talking?
I think
If,
so,
if
but
it is, that's okay. I'm gonna do something really quickly. So I'm gonna go off camera and then I'll go back on camera.
okay.
Do we know the order for this part?
I am trying to
Yes, we'll
remember.
start with Jasmine because she has more slides, and then after hers is the brochure that you sent, and then we'll move into the discussion.
Perfect.
We'll try and keep the presentation part light because we've been having really good discussion
Nice.
today where people have tons of questions. So that's really wonderful.
Sure.
So everyone's pretty engaged. And a lot of people came back after lunch.
Awesome.
Yeah. Oh, good. Here's our youth to answer all the questions.
He's the chosen one right here.
Yeah.
Hey.
Hi. Well, let's get started in like another 2 minutes or so. Do you have any? We're live right now, but do you have any questions before we get started with the panel?
No questions.
Okay. Well, thanks for being here today.
Of course.
Tell them about that too. What you guys were talking about over there. Pretty cool.
Yeah, I'm just gonna share about who the school's for and then oh shit.
All right, welcome back from break, everybody. We're going to go ahead and get started with our fourth panel of the day on adolescents and fentanyl. So I will turn it over to Allison, I believe, to moderate the discussion and the panel.
Yeah, thank you so much, Katie. This is our final panel of the day on a topic that I think is of a lot of interest